First, before we get started, I want to make sure that everybody is in the right place. This breakout session is for prostate cancer. So if you're not interested in learning about prostate cancer and its new treatments, you need to find the room you want to go to. So with that said, my name is Joel Nowak. I am a multi-cancer survivor, including a 13-year metastatic prostate cancer thriver. And I underline that word thriver because I thrive, and we all can learn to thrive. And we have new opportunities available to us today that will allow us to live and thrive. And we are very fortunate today to actually call back to the microphone Dr. Zachery, who just gave us that fantastic presentation on genomics and genetics. And he's going to take the first part of the session and talk about the new treatments for prostate cancer, because there is a plethora of new treatments. And we are so lucky because the landscape has so changed. And it gives us all something that's, I find, the most important thing for a cancer thriver, and that's hope. We all have hope, and we all need to understand and rally around that. After a presentation, he and I are going to have a conversation about some of the new treatments, and I'm going to pose some questions to him. And then we are going to get off the stage, and we're going to have a panel that's going to talk about a whole bunch of different issues. So with that, Doctor?
Excellent. So people that are up high, please come down low. There's lots of seats down here. It might be easier to see. And then also, as we get to the dialogue and the question answer, it'll be a lot easier to do that when we're all sort of in the same area. So what I'm going to talk about today is going to be sort of big picture prostate cancer. And I think the reason I say big picture is because prostate cancer is very different depending on what phase of the disease you are in. As you look around the room, there are some people that are struggling with just having been diagnosed and not knowing, and with the cancer only in their prostate. And so they're struggling with the idea of how am I going to approach my cancer right now. There are patients that have their prostate that got taken out a while ago, but yet now their PSA is back. And so there's a lot of anxiety and emotions because they're talking with their doctors about, is there anything they should do with that scenario? There's other patients sitting around us that have had the cancer come back, and we can see it on the scans. And so they're starting new treatments, and they're not sure how those treatments are going to work, or what are their symptoms going to be? How is it going to help them live longer and thrive with their disease? And then there's patients who have gotten a lot of different treatments, who have tried a lot of different things, and their cancer is tricky and getting around it and continues to grow. So we're all facing our struggles, we're all facing our difficulties, but prostate cancer covers all of them. So we're going to cover sort of that big phases of the disease as we go, but ultimately all of them come down to this slide, that if there's one thing I want everybody to walk out of here with, it's this idea, is that every step of cancer care, every step that you are doing, is you're balancing. You're balancing risk and benefit, which sounds really silly, like, of course. But you have to think about it broader than just that. So this risk and benefit, for risk, obviously there's risk of the disease itself. And so that's the risk of symptoms from the disease, like urinary symptoms, like pain, like fatigue from the cancer, and possibly symptoms like a shortened life. Those are balanced also with risks of treatment. So side effects of treatment. Are those side effects short-term, where they're only going to be for now, but I should recover? Are they long-term, in the idea that there's a potential that this may not get better if we have something that happens? And then also the financial toxicity that we've talked a lot about today. You know, how is this going to impact my life? And I want to broaden it from, we talked a lot about pill-based medicines, to the idea of, you know, I may have to get a surgery. I may be out of work for a while. I may have to get radiation. I may be tired, and I may have to take time off, or I can't help take care of my family during treatment. So I want to think about it broader than just dollars and cents. And then the benefits of treatment. Thank God, in some cases of prostate cancer, when we're talking about earlier phases of the disease, we're talking about a benefit of cure. That we can treat the cancer and it never comes back. That's a pretty darn high benefit. That it would balance that with a decent amount of risk. But again, each patient's experience and expectations for that are different. The other benefits of treatment can be delaying symptoms. It can be improving current symptoms. So if there are problems right now the cancer is causing, we might be able to make them better with treatment. And then I strongly mention this also is that there's benefits of monitoring a cancer. So sometimes, as I mentioned earlier, now is not the right time to do treatment, whether that be because of things going on in the life otherwise, there are other medical problems, or it's a cancer that we can monitor very safely, such that monitoring is the best choice because there's no side effects from a treatment of just monitoring except for the emotional parts around that. And so focusing on how do we manage those parts. And then the important thing is, though, is that with all of these ideas when we're talking about monitoring is that we have a lot of safety data, that if it's done in the right way, if it's done in the right part, men who are monitored for cancer in the right context can live just as well as men who get treatment. So now I emphasize in the right context because it is not everybody that that's the right phase for. And it gets to the idea of what are the phases of prostate cancer. So we're going to do a little 101 here. So ultimately, even if your cancer, when it first was found, was elsewhere in the body, it started in the prostate. So all prostate cancer, even if it never was found at that point, was started in the prostate. So it was localized in the prostate. With prostate cancer screening, we find more men like this, where the cancer is only in the prostate, but we're going to call that clinically localized disease. So localized, it's only in the prostate. Disease, obviously the cancer. So some people get treatment for that, some people don't. And then let's say the PSA starts rising again. This is unique. In other cancers, there's no blood test. Actually, in the vast majority of cancers, there's no blood test. So it's a burden and a benefit. So we have the PSA that can be rising. So we call that biochemical. So blood test, biochemical, recurrent, got treated before, and now it came back. Prostate cancer. And from that point, depending on your discussion with your doctor, there's different roads now that you're going to start taking, sometimes monitoring or sometimes treatment. The issue is at some point, there's a possibility that metastases develop. So what metastases means is that the cancer shows up somewhere that it shouldn't. So it shows up in lymph nodes, it shows up in bones, it shows up in organs. It has learned how to travel in the body and gone somewhere else. So, and you'll see that I mentioned that there's metastases with an intact testosterone, and we're going to get to that a lot today. But the idea is, so our testosterone is normal in that scenario. So you'll see that, you'll hear your doctor say metastatic, so it went somewhere else. Hormone sensitive, HS, that means the testosterone treatment is highly likely to work. Prostate cancer. Another road, depending on the discussion with you and your doctors, would be as if you started treating the prostate cancer with hormone therapy or with anti-testosterone therapy, and then the PSA starts rising again. So it went down, and then it starts coming up. So that's called non-metastatic. So if we do pictures, sometimes we don't even see it yet. Hormone resistant, so that means the testosterone is low, and it's still growing. So that means it's resistant to the original hormones that were used. Disease, prostate cancer. So again, I don't emphasize a lot of the doctor talk, but I think it's sometimes useful to hear it at least once, so you know then when you hear your doctor maybe say it when they're stuck sort of thinking doctorly. Non-metastatic, so it's NM. Castration-resistant, so that's where the low testosterone, it still is growing. Prostate cancer, so nmCRPC. From either of these phases, because oftentimes you'll be getting treatment in one or in monitoring if the cancer starts showing up on pictures. So we have new pictures showing new cancer. So again, the cancer has gotten tricky and gotten around our first treatments. We call that then hormone metastatic, because we see pictures of it, hormone-resistant disease. And the great thing is you'll see I say treatment 1, because oftentimes we'll start a new treatment at that time. And then if that treatment doesn't work, we have treatment 2. And if that doesn't work, we actually have other treatments. And that's what you mentioned, that we have many treatments now for prostate cancer that we're going to mention, that we have a way to try to manage the cancer as best we can. And this late phase, here you'll hear your doctor say mcRPC. Again, doctorly talk, M, metastatic, CR, castration-resistant, which means low testosterone, and it's still growing, prostate cancer. So you'll see here I have blue pictures and then I have, I guess, orangey pictures. So the blue pictures are the phases of the disease where the testosterone starts out as normal. And then you'll see the orange ones are where the phases of the disease where the person is going to have a low testosterone. The only caveat here that I want to mention is that with with this group, you will have both of that at one point. When you start in that group, your testosterone will be intact, and then it will be treated and become low. So this is actually could be both colors, but I thought that was a little confusing. So you see testosterone is mentioned a lot during, as I've mentioned, in the different phases, how we describe it, how we treat it. And I think that's critical because ultimately testosterone is the fuel for prostate cancer cells. So testosterone is what keeps the cells growing. It's what keeps them happy. They like it. It keeps them surviving. So the first treatment for oftentimes when the cancer has spread is to attack the fuel of the cancer. The issue is, as we've talked before, everything is risk and benefit. So when we lower somebody's testosterone, and I'm going to mention this is different when you hear about people saying, oh, I have a little low testosterone, and my doctor said they were going to put me on some medicine, who don't have cancer. That is different. This is medically lowering the testosterone very low, is that it does cause symptoms. Symptoms like hot flashes. I can't tell you how many spouses love it when I say that. They say it's about time. So, personality changes. Some men actually will find that they feel their personality has changed. Heart stress. We know that a low testosterone environment somehow stresses the heart. We don't exactly know why, but we know that it does a little bit. Bone loss. We know that over time, having low testosterone makes our bones weaker, makes our bones at risk for fracture. So these are things that your doctor's thinking about and that you need to think about. How do I prevent these things? Exercise, vitamin D, talking to your doctors about it, because sometimes we do tests to evaluate these things. Memory. As we've done this more and more, we feel that we've learned that there may be some memory effects, typically for when patients have been on it for a long time, that we still don't really understand and we're trying to understand better. Metabolism, on average 5 pounds of weight gain. Fatigue. I think I like this analogy. One of my patients told me, he was a runner, and he said, my mile time was 7:45. He's like, I started therapy, and he's like, I can still do my mile, but I'm doing it in 8.5 minutes now. So he's like, I've slowed down a little bit. And I think that captures a lot of things patients sometimes tell me where they say they've slowed down a little bit, but I tell them to keep running that mile because that's important for the bone loss. Keep being active because these things can combat what we know the side effects of this are. But it's important to go into it knowing that these things can happen. And then sexual dysfunction. I'm going to spend a little time on that because it's a little different when we talk about low testosterone sexual dysfunction than when we talk about sexual dysfunction from like surgery or radiation, which is a lot of what we talk about for men that haven't had their have not had the cancer spread or need these kinds of treatments. This is a central effect. When we lower the testosterone as a man, it sort of changes how we think about sex for many men. Not everybody. This is definitely not universal, just like not everybody has every one of these things. But it's important to know that some men do find that their interest in intercourse changes. And then with that, sometimes their ability to obtain an erection might be hindered, or maybe that's separate. It's important to talk about these things because we're way too good, especially as men in the United States, to shove this stuff down, not talk about it, not bring it up with the doctor, not do anything about it. But these are all the things about your life that we need to make your quality of life as good as we can with the treatments that we need to do. And so talking about it, they have sexual dysfunction clinics that talk about these things. We have treatments that we do to try to make our quality of life as we're dealing with these things as good as we can. So there's no reason to hide this stuff under the rug or to feel that it's not manly to talk about. All of your life is important to us as your doctors, and all of your life should be important to you. Just because we're dealing with cancer, just because we're talking about cancer, does not mean you should ignore the other things about your life that make your life a good quality. And all of these things can do with it. I'm going to leave the mile running out. That's not making my quality of life any better. So one thing that you noticed through all of these things that I mentioned was the idea of seeing things on the tests. So I talked about, then when we see the cancer in the bones, or we see that it has gone somewhere else, when it has metastasized. Well, depending when you see something, it is dictated by what you use to see it. So we have lots of different things that we've used for a long time for prostate cancer. And this is probably not even a complete list, because we're still learning new ways to look at the cancer. But they're all appropriate for different settings. So again, you and your doctor should talk about what's the most appropriate test for you to figure out what's going on for your cancer. One thing I'm going to bring up, because we did mention that we're looking at both what's going on now and what's potentially coming up in the future. And so I'm going to mention what I'm going to call PSMA-based scanning. Prostate-specific membrane antigen, PSMA-based PET scan. So what that is it uses a molecule that can connect to the PSMA part on the cell and light up. So by binding to the prostate cell, maybe we can see the cancer better. So there's a lot of clinical trials and development, and the other areas of the world have approved this diagnostic test. So we're still figuring out in the United States how important is it and should we be doing it. And here's an example of what it can look like. I'm going to emphasize not every black spot on this patient is cancer. And that's the idea that you need to make sure to work with your doctor who knows how to look at the scan. Ordering a scan and doing a picture that you don't know how to interpret is not taking care of you the best way. So again, you need to talk to your doctor about what they feel is the best way to learn about these things for you, but you can ask them about things. So just as an example, for this patient, these are the kidneys. That's not cancer. These are the salivary glands. That's not cancer. So you need to make sure that you understand what you're looking at, not just looking at a picture. So what I want to emphasize is the idea that technology you use to find the disease, so what technology you use will dictate the potential of finding it. So here's a good example. When you're at Ford Field, if you're sitting up in the nosebleed seats and you're looking down at the game and you have the $5 binoculars you bought when you walked in there, you're going to see the game a little bit better than if you had no binoculars. But what if you had $300 binoculars? You might be able to see the field a lot better. The game is the same, whether you see it with the little binoculars or the big binoculars, but you might be able to see it differently. And so as we now figure out different ways and we learn about the new binoculars that we are getting, we may be able to make a difference on the field by making different decisions. And that's the next phase of how do we use these things to make better decisions for all of you. So this is going to be a little bit of the rapid fire because I want everybody to hear something that applies to them. And everybody's coming into this at different phases. So clinically localized prostate cancer. Treatment things people think about, active surveillance. Emphasizing active. This is not just saying you were in cancer, we're going to not think about it for another year. This is actively monitoring for it. For the right patients, it's a very good choice. The things that you and your doctor need to talk about are things like your age, your general health, what else is going on in your life and your body. The risks for your cancer specifically when they look at it under the microscope. The active part, this is usually involving pictures, so like MRIs, prostate biopsies, physical exams, PSA testing. It is actively monitoring the disease. And then also knowing that within that monitoring that 1 out of 3 men in active surveillance will need treatment. And that's because you are actively monitoring for any risk of the disease changing. Surgery is another thing people will consider. Again, the same things are important. Person's age, their comorbidities, what else is going on in their life, what is the risk of the cancer itself, and then the doctor's talking about the different types of surgeries that they do. Do they need to do surgery? Do they need to treat the nerves? What's the risk of leaving the nerves? Should we take out lymph nodes? Should we not take out lymph nodes? These are things that your doctor and you need to talk about. And then radiation. Again, your age, your other things going on in your life, what other risks are going on. Prostate cancer, again, what is your prostate cancer risks that are playing into this? What type of radiation given? Should hormone therapy, should that low testosterone treatment be given with the radiation? What type of radiation? There's a lot of different types now. The duration of it, and we're learning a lot more. So rising PSA. So this is the group where I talked about after getting treatment, their PSA has come back and is rising. So this monitoring is very appropriate for some men in this case. So again, considering the same things, that's relevant throughout every step. Sometimes we do radiation, depending on, again, the factors of the cancer, the patient, and what's going on with them. And then hormone therapy is considered also, again, depending on the patient's, what's going on in their life, the risks of doing it, what is the expected benefit. What I'm going to emphasize, and this is just a limit to our understanding right now, that this is a big discussion of risk and benefit. We've tried to do research in this space. It's really hard because there's so many variables that go into it. So you and your doctors need to talk about what is the risk of doing something, what is the risk of not doing something, what is the benefit of doing something, and what is the benefit of not doing something. And so this is where again, that dialogue between you and your doctor is so important. So this now is the group that had treatment, so their PSA was going up. They started anti-testosterone therapy. Their PSA went down, as over 98% of men it will, but then over time it started going up again. So what's really exciting here is we'd continue the testosterone lowering therapy, because remember from the last talk, your prostate cancer is not a cornfield, it's a prairie. There's lots of different types in the body. The hormone therapy is probably working for the vast majority of it still. But some cells just figured a way around it. So you're trying to really not target everything. You're trying to, how do you target those cells that got tricky? And this is really exciting. So there's 3 treatments now that we have in this. Enzalutamide, Apalutamide, and Darolutamide. And if you notice, I put up there also when they got approved for this. These were all approved within the last year and a half. So a lot of changes are happening as we've learned more about this cancer and done the right types of trials to learn how to make sure people are benefiting. So now this is another space that's changed dramatically. So this is where the cancer has spread, but the testosterone is normal. Some men, this is the start of their road. Other men came to this road over time. So for this group, again, that testosterone lowering therapy is the backbone. 98% of men, the PSA will go down with that treatment by itself. But through good clinical trial work and learning about the cancer, we've learned that doing what I call treatment intensification can make these treatments work longer. And so that intensification strategy can be chemotherapy for a short time with docetaxel. Or it can be other oral treatments like abiraterone, or Zytiga is the brand name, or Apalutamide. Again, look at the years that these were approved for this use. All within the last 4 years. So by doing the things right, we're taking better care of people longer. So these now are patients who have been on treatment. Their testosterone is low and new things are showing up on pictures. So castration-resistant or hormone-resistant disease. So again, you continue your low testosterone treatment because as there is still cells that is probably still controlling. And there's many treatment options that then can be considered to add into the treatment plan. Again, chemotherapies, docetaxel, cabazitaxel, depending on the right situation, oral treatments like abiraterone or enzalutamide, IV-based radiation, radium, or an immune-based treatment called Sipuleucel-T. So there's many different choices that you and your doctor need to work through. And again, risk and benefit. What are the risks of these treatments? What are the side effects that they can potentially cause? What's the likelihood that they may fix the problems going on? If pain is a problem, when would we expect the pain to get better with the treatment? So what is the kinetics of that response? These are all things that you got to talk with your doctor about to make the best plan for you. And then ultimately plan ahead for what's the next steps to look ahead. So what's the future for this area? So precision medicine approaches. We talked about this a little bit earlier, the idea of how do we learn as much about your cancer to possibly target things that are specific to your cancer. So we've DNA repair defects. So these are, we talked about the idea of cancer being a genetic disease. If your DNA has inherent issues with repairing itself, maybe we can target that with treatments. There's treatments approved for breast cancer, ovarian cancer, using this philosophy, and the clinical trials for doing this are starting to come out now, and so maybe this will be the next phase for prostate cancer. Microsatellite instability, another doctory term, but ultimately this is for cancers that are very, very mutated, have those sentences are really messed up, much more so than the general population, oftentimes from an inherited cancer syndrome. Those patients actually already have an approved treatment for them with immune-based immunotherapy. So that, again, that option, if that's been evaluated, could be an option now based on the approvals. So PSMA-based therapy. So we mentioned before the idea of using this to find the cancer, but instead of putting something on that molecule that just tells me this is where I am, maybe we can take that homing signal and connect it to something that damages the cell. So connect a drug to that tracer molecule to bring the treatment to the cancer in the body. So we had this picture from the last one. So that patient underwent a PSMA-based treatment, so that combination, and after treatment, their scan got better. So this is exciting new stuff that we are learning about to hopefully push the envelope and make people live longer and live better. But I just want to emphasize again that this is a tricky cancer, as many are, and it's not all the same. The cells change over time. The subclasses, one patient has more than one type of prostate cancer in their body at the same time. They're all a little bit different sometimes. So this is an example that just got published. So this is a picture of a patient. They did a biopsy of 2 different sites. One, let's say one on the left, one on the right. They then took a marker and said, anything that has that PSMA tracer, we're going to color that red. And so they took both of those tissues and stained them red. And if you see, obviously this one, very red, and this one not red at all. They're both still prostate cancer, but yet one would be targeted very well by that PSMA treatment, and the other one wouldn't. And then, well, maybe it's close enough, and that even within the same biopsy, within the same needle being put in and out, you can have areas that are red, and then 2 millimeters away, 2.5 millimeters away, you can have areas that have no red at all. So this is the idea we need to keep thinking, just as the cancer is tricky, we need to keep thinking of ourselves and doing new things and trying new ideas to try to treat all the cancer and manage it. So we have some discussion.
Thank you very much. I think that was quite informative, and you gave us a whole lot of information very quickly. So in the course of your presentation, I jotted down a number of questions.
Great.
Again, from a patient perspective, and having the opportunity to interview a practicing oncologist is going to be interesting. So my first question is, we hear a lot about how we as patients should be making our decisions for treatments. And the big hot word today we hear is shared decision making. Could you talk a little bit about that? And from a perspective of a doctor, what's your opinion of it, and where do you go with it?
So I love it. So I mean,
Can you explain what it is?
Yeah. As we've mentioned, as I've said, you need to talk with your doctor about what's important to you. And so that's where it's the only way for us to know what you want out of your treatment is for us to ask, and then for you to tell me what's important. So shared decision-making means that I, as the doctor, know what our treatment options are. You, as the patient, need to tell me what is important to you and what things our goals are of treatment. And then we go back and forth and talk about, well, this is what we can achieve, this is what we can't achieve, this is the likelihood of this is the likelihood of that. And we go back and forth about making out your treatment plan to meet your goals of treatment, to meet your goals for your cancer. So I use it a lot in my practice. I strongly agree with the idea that this is a two-way street. So the only way for me to know what's important for the patient in front of me is for me to ask and for you to tell me. And if your doctor hasn't invoked that from you or said, you know, what's important for you out of this treatment, say this, you be the one to say it. Say, you know what, my goals for my life are this right now. And then the doctor then can play off of that. So nobody can advocate for you better than you. And this also goes to the caregivers in the room. You are part of the team. You can speak up as well. There's a lot of great data and a lot of personal experience in the idea. I get great questions from spouses, kids, in-laws, everybody. Everybody is here ultimately to help take care of that patient and that family unit. And so everybody who wants to participate should be there if they can to help with that decision-making together, because ultimately everybody brings different information to it.
Great. So unfortunately, not every doctors are as flexible as you are. So my advice would always be, if you're not getting what you need from your doctor, what's really important is to find the doctor that's going to give you what you need. There are a lot of doctors. We're all lucky. We're sitting here. All of you are living in Detroit. There are options. There are more than one doctor. You can travel a little if you need to. Not that I'm suggesting that the treatment issues that you have right here aren't fantastic, but you should always feel free to use everything that's available to you to make sure you're getting what you need. I think it's really important. I'm going to jump around a little bit.
Sure.
So you talked about monitoring prostate cancer when someone's initially diagnosed. That's referred to often as active surveillance. Unfortunately, if you look around at different facilities and different practices, the protocol for how active surveillance is actually practiced, there's no consistency. So how does one go about figuring out what protocol makes the most sense?
Yeah, so that is a really tough part, because think that to do an active surveillance study, to learn that this treatment is a good idea, and by treatment I mean surveillance, you have to watch patients for 10, 15, 20 years to really get an idea for a cancer that acts like ours. As we've learned more, you saw all the different diagnostic tests that we've learned that can be helpful. Those came out after those original tests were done. So the idea of what is the only right monitoring plan, there is not one monitoring plan that is the only right answer. So you may see one doctor and they say, we do a PSA, an exam, and a biopsy every year. You might see another doctor who says, I do a PSA, an exam, and I do an MRI, and then we do a biopsy the next year. What I would say is you need to talk to the doctor, and ultimately when they're talking to you, if you feel that you have a good relationship with them, that's as important as the monitoring plan, as the plan that they execute. So if they say, if you meet somebody and they're like, yeah, we're going to do that, and you feel that they didn't listen to you, or you feel that they weren't engaged in the surveillance program that they were presenting to you, that may not be the best surveillance program for you. So I think in the idea that we don't have one right answer for it, your relationship with the doctor and the team around them, and that means the nurse practitioners, the PAs, the nurses in the office, all of them, you need to have a good relationship and your confidence in them. And if you don't, you need to find someone else then who you do have that relationship with.
Great, thank you. I appreciate that answer. You touched on something really important. I was at a discussion yesterday where we had, I think, 10 or 12 men who had prostate cancer, and the question was asked, and there was a series of questions that had to do with bone health, just so you know where I'm going. There were 8 or 9 questions that men were supposed to answer and talk about, because this was a chance to learn about what men know. And the first question on that list, and this was a survey done by us too, who is our sponsor today, was who told you about the importance of bone health? And we had 12 or 14, whatever it was, men with prostate cancer, and not one man said that they had anybody ever tell them about the importance of bone health. I mean, that was stunning. Wow. Now, I have metastatic prostate cancer. I've been in treatment for 13 years. I know about it, but as I thought about it, no doctor ever told me. So I think it's important if you could talk now about why bone health is so important and why we as patients need to have our doctor talk to us. We need to ask them because based on that experience yesterday, they're not doing it.
So that is a failure on our part. And this is something that we have learned more recently in the last 5-6 years, how critically important bone health is. And we just haven't always taught people about it in the right way as doctors. So the experience that you saw, unfortunately, is a reflection of our failure. But the issue is it's critically important. So the thinking that this is a cancer that one likes to go to the bones, so that's where it likes to travel to if it has spread, and the treatment that we use, the low testosterone treatment, harms the bones over time. That is a combination that is not good. So the idea of how do we then try to minimize that risk, because this gets to the idea of what is our long-term goals for our quality of life. So the reason that I worry about bones so much as the doctor, and I talk about it so much, is that when we have problems with bones, that's bones fractures. So that's a bone breaking. That is a major quality of life detriment for that patient in the room, from obviously pain, but then also mobility. And then with that comes risks of other issues like pneumonia, like bed sores if they have to be in bed because of the fracture. And as we get older in our life, those other things can also be life-threatening. So actually fractures can be sort of the initial road towards a path that shortens somebody's life. So the idea of focusing on bone health, because it's a marathon, not a sprint. Once we have a fracture, we can do things to try to help with it and try to help it heal, but we're sort of already maybe behind a little bit. So the things that I talk about with my patients for bone health, one is vitamin D is a sort of low risk. I will be as honest, there's not a huge amount of data saying that it makes it critically important, but on the same time, it's pretty low risk. So I see the risk benefit again to be towards doing it. So I have my patients take a low dose vitamin D every day. Exercise, critically important. And not just exercise of going out for a walk, but actually exercise that stresses the bones a little bit. So lifting something with a little bit of weight. And by weight, I'm talking 5 pounds. I'm not talking, doing bench presses with the rock. I'm talking small amounts of weight that just put a little stress on the bone, because when our bones get stressed, it tells them to build. So that little bit of physical activity, that bone stress, can keep them strong over time. And then depending on with you and your doctor may do screening for low bone density. So when women have their hormones go down as they get older, they get screened for bone loss with bone density scans. Sometimes we will do those things for our patients. And then depending on the risk, both in mixing the cancer with the bone risk for that patient, sometimes we do treatments to try to keep the bone strong. And those sometimes are infusions or injections that in the right scenario, we add into the treatment also to prevent bone fractures and the quality of life detriments that they cause.
So at what point in progression should a man start asking these questions if their doctor's not raising it to them?
So the biggest risk for bone health is when your testosterone is going to be treated. So if your doctor says we need to lower your testosterone with treatment, that should be the red flag that is placing your bones at risk in the future. And again, this is not an immediate risk. This is a risk over time. But it's always better to stay on top of it earlier than to get into trouble later. So if your doctor said we're going to start hormone therapy and decrease your body's testosterone, that's the time I would bring up saying, what should I be doing for my bones, and should we be monitoring them somehow to start that discussion?
So there are, as you referred to, some drugs that are used
Absolutely.
to protect or strengthen the bone.
Yep.
Can you share what those are
Sure.
and when they should be used, and also what some of the issues around them are?
So the drug classes, there's 2 different ways that we use these drugs. So I'm going to mention them just so you've heard them. Sometimes we use them in a way that we're just trying to keep the bone strong, I'm going to say on the long term. So that's where we're really thinking in the long time frame. So those are more time we're using them to prevent further bone loss, like osteoporosis or osteopenia that you've heard about. And we're using them in sort of a longer time frame where it may be a shot every 6 months. It may be an infusion once a year. So that's sort of the prevention, and the main risk, and the risks are going to be consistent, so I'm going to talk about them after I sort of say the different uses. Once the cancer has spread and the cancer is growing in the bones, that's a different risk period, because the risk of it causing issues there is much higher because we have cancer damaging bones. So we use them more intensely at that point, and sometimes we will use them every 3 months, and sometimes we'll use them once a month to, again, try to reinforce the bones to keep them strong and to prevent pain, which these things also have been shown to do. If you think about it, our bones are always breaking themselves and rebuilding them. As we grow, that's happening a lot, and that's how our bones grow. As we get older, our bones don't need to grow so much. So most of our bones are not turning over as much as they used to. But there are some areas that our bones do turn over a decent bit, and that's up in our jaw. So we get infections, our teeth have issues, so there's a lot of growing bone and breaking bone to keep our jaw healthy. And so that's where these risks for these treatments that are pushing the bones to grow more than break down can have some risk. And so that's called, again, it's called ONJ, or osteonecrosis of the jaw, and that's where the jaw doesn't heal well from if it gets an infection. And that's the idea of, again, prevention is the key. So keeping your teeth healthy before you ever need these drugs. Seeing your dentist before you start them to say, is there anything that we should be doing to prevent issues in the future? Sometimes that is, we have to remove a tooth because it's having issues. Sometimes it's just, well, let's get a cleaning in before we start. So it's a variable, but on the same time, preventing issues in the future is most important. There are short-term issues with it. Some patients get achy for a couple days after them because it's targeting the bone environment. So we can use Tylenol and things like that to help. And then also these medicines are processed by the kidneys. That's how your body gets rid of them. So your doctors just need to make sure that they're using the right dose and such for you. But from a quality of life standpoint, on the broad scheme, it's the dental health that I really focus on. And again, staying on top of it before we need all of these drugs is the best way to prevent issues in the future.
What about femur fractures?
So there is data for patients that have been on it for a long time to possibly increase the rate of femur fractures. That data is predominantly from women that have used it for osteoporosis. So those are women without cancer. The issue is when we're using these medicines in the intense way, in the scenarios our risk of fracture already is very high from the cancer and from the low testosterone environment, such that if our risk of that is already high, I think it's balancing out well for that risk for prostate cancer-specific patients.
So as you said, it's always a risk and reward. And nothing comes without a risk, even taking an aspirin.
You got it,
yeah.
And which people are doing less now, too.
So as men who have metastatic prostate cancer, and men also who are even not metastatic, we know PSA is one of our biomarkers that we rely on, one of the ways we try to measure the progression or lack of progression of our cancer. Mm-hmm. PSA is controversial, but it's really controversial only for purposes of screening and initial diagnosis. But my understanding is that it's not when it comes down to people who have been diagnosed. But we have treatments, and a lot of us look at treatments and we say, well, my PSA was 100. I took this drug, and now my PSA is 50, and then the month after that it's 10. So I'm operating under the assumption that that drug is working for me. So there are two issues I want to talk to you about. First is immunologic therapy, immunotherapy. Mm-hmm. You touched on it briefly in your presentation. Mm-hmm. PSA and immunotherapy are problematic. Mm-hmm. And could you share a little bit about that and where the issues are and how we should be thinking about it?
So I'm going to take one step back and emphasize the PSA critical nature of it, because I think you touched on it, and I can't emphasize this enough. The PSA for finding the cancer is a discussion you have with your doctor. If you have already been diagnosed with prostate cancer, you're not screening anymore. The cancer has been found. So it is a monitoring strategy. So that is very different, and it is a tool that we use. For many treatments, it does make the PSA go down. The issue is we also have, I'll expand it, there's two different treatments we have, both the IV-based radiation and then also the immunotherapy, the Sipuleucel-T, that do not make the PSA go down. When we did big studies where we gave these treatments to men, Half the men got the treatments, half the men didn't. We looked at them, and the men who got the treatment lived longer. And let's focus on the big picture here, which is how do we make you live as long as you can, as well as you can. And so as the doctor, it's my job to educate you to say, before we start these treatments, to know that this treatment is not going to do those things. So you know going into it, it's not going to do that. But as the doctor who's done it, who's read the literature, who has given it to men, these medicines have been shown to make you live longer. So we have to know that that is the truth behind it and sort of get away from that PSA aspect a little bit at that point.
Thank you. I appreciate that. Unfortunately, we've run out of time.
Oh, I'm sorry.
We have no, don't be sorry. It's my fault. I'm the moderator. But I want to thank you very much. I have a stack more questions, and I'm sure other people do. So later on, you're hanging around. Would you be okay with people grabbing you?
Absolutely.
Terrific. Thank you so much. Appreciate it. Thank you very much.
Thank you, Dr. Reichert, and thank you, Joel. My name is Chuck Strand. I'm CEO of Us2 International. We're a prostate cancer nonprofit that's focused on providing educational resources, support services, and personal connections to the prostate cancer community. And I just want to take this opportunity between the two breaks. That first session from Joel and Dr. Reichert is going to be followed up with a second session now with a panel and moderator. But just wanted to thank Karmanos Cancer Center for hosting this event, and also wanted to thank our sponsors. So this is really an event within an event. So Us2 has a Pathways event series, and so we have our sponsors that are specific to this in addition to all the companies that are sponsoring the Karmanos event. So the Pathways sponsors, we would like to thank Astellas Pfizer, Janssen Oncology, Amgen, Genomic Health, Clovis Oncology, Dendreon, Advanced Accelerator Applications, TIM Medical Technologies, and Euromedica. And I also wanted to thank the team at Us2. Terry Lukowski is here with me today. Tim Mix is at the home office, has worked really hard on this event also, in addition to James Hudson and Jackie Konikska. So at this point, I'd like to turn it over to our moderator, Jim Schrate, who's also the chairman of Us2, and we'll get into the second session here. Thanks very much.
Good morning. I'm Jim Schrate. I'm a 9-year prostate cancer survivor. And as Chuck said, I was honored to be elected chairman of the board of Us2 last December. We're going to talk this morning about some of the very difficult issues that surround prostate cancer diagnosis and treatment that don't always get enough attention. Those would be emotional issues, including anxiety and depression, and even suicide. Then we're going to move on to the medical treatments for erectile dysfunction and other forms of sexual dysfunction. And then finally, we're going to talk about intimacy issues and how the effects of treatment or even the effects of diagnosis affect personal relationships. In working with support groups over a number of years, I've found that these issues cross the whole spectrum of prostate cancer. They come into play in diagnosis, treatment, and recovery. So it's something that you have to be prepared to deal with from the outset. I've also got to add one plug. You'll hear this morning about professional services that are available for help with these issues. But one of the most important things for me personally has been participation in support groups. And you need to look at that as an option and think about how that works hand in hand with what you're trying to do. We sponsor 200 support groups nationally. For people who aren't comfortable with that, we also have available on our website information about dial-in support groups. And some of these are specific for newly diagnosed versus advanced and that sort of thing. So I would recommend all of you look at that, because it's a resource that you should consider. I'll let our experts introduce themselves and kind of give you an idea of where they fit in the discussion. And then I'm going to talk a little bit about my own story, just to set the table a little bit. So, Baha.
Good morning, everyone. My name is Baha Malaib. I'm a reconstructive urologist at the University of Michigan. I specialize in penile urethral reconstruction as well as rehabilitation and restoration of sexual and urinary functions after treatments for prostate cancer or other cancers.
I'm Gary McLean. I'm a psychotherapist, and I work with clients who are living with chronic and catastrophic medical diagnoses.
Hello, Detroit. I am Shelley Imholt. I have a PhD in clinical human sexuality. I have a practice in Austin, Texas, where I do sex therapy. I work with prostate cancer survivors, breast cancer survivors. The one thing that I do know is cancer does not discriminate, and nor does sexuality. So I'm here to offer some ideas for all of you. Thank you for having me.
All right. For all of us involved in prostate cancer, it really begins with our story. My story is that I was diagnosed at age 58 with prostate cancer by virtue of rising PSA. I underwent successful surgery, but found that I was completely unprepared for the consequences of that surgery, notwithstanding the fact that I was treated at a prominent teaching university hospital. That led to depression. I didn't know what depression was. I knew I didn't feel right. I couldn't sit through a meal with close friends. I felt alienated from my family, and I didn't get it until I became suicidal and sought treatment. So as part of that, I became involved in the support groups, and I've been involved ever since. So for me, it was about knowing what to expect and preparation, and I think that's really, really important for every newly diagnosed patient. And then the second thing is to recognize the issues as soon as possible, because the earlier you can get help and you can get treatment, the quicker you recover, and the quicker those around you recover. So with that, I'll turn it over to Gary.
I'm going to start, well, first, this is a homecoming for me. I live in New York, but I grew up in Jackson, and I went to Albion College and Eastern Michigan University and University of Michigan. So this is a real homecoming and a pleasure and honor to be here. I'm going to tell a very quick story. I'm going to keep this very brief, just so you know. I'm going to tell a very quick story. I know the stories can go on. This one won't. In another life, I did communications research. I worked with pharmaceutical companies and hospitals, treatment centers, talking about the patient's journey. And I have a few notes I'll be going through. And in my interviews, I would often ask the question, how do you feel? And I would hear about side effects, anemia and nausea, other side effects, and I would say, how do you feel emotionally? And so often, the people I had interviewed had never been asked that question before, weren't having those discussions. Their treatment team had another focus. That's changed, I just want to add. Their family, nobody was talking about emotions. It was an elephant in the room. And often people would wait for me outside after I interviewed them. And they would say, nobody ever asked me how I felt. I really appreciate that. I never talked about my emotions. So I decided maybe that needed to be my calling for the next chapter of my life. So here's where I am. I have a website, Just Got Diagnosed, where I write a lot of articles and things that I do in my work. My focus is helping clients cope with the emotional impact of illness, of decision, of chronic catastrophic conditions. We talk about making decisions, spend a lot of time on difficult conversations, and I think maybe life is a series of difficult conversations, but certainly if you're on on the road of medical treatment, there are a lot of difficult conversations with partners, in the workplace, with healthcare professionals, conversations like disclosure, talking about emotions, asking questions. So we spend a lot of time, my clients and I, their patients and caregivers, talking about the initial shock, the emotions that come up when someone has a diagnosis, and this is an ongoing process, as you're all the experts on. Fear, anger, sadness, basically lots of changes that you didn't ask for. I often call a medical diagnosis an uninvited house guest. It's moved into your house and it wants breakfast in bed, and it's taken over the TV, and it's making all the rules you didn't invite. You didn't invite them, but they moved in with you. It means change, and it means loss. And the word I would also use is grief. I think there's a grief process that someone who gets a medical diagnosis goes through, and it can be an ongoing process also. Loss. So 2 words that have already been mentioned are 2 words, depression and anxiety. And I just want to honor doctors who are screening their patients for depression and anxiety. What a miracle that is. And most of my referrals to my practice come from physicians who said, you need to go talk to this guy, make an appointment. Very quickly, depression is helplessness and hopelessness. It's feeling overwhelmed by the fear factor. It's shutting down, again, grief. Anxiety is trying to live with the uncertainty of a chronic condition. And if nothing, well, there are many lessons you learn from chronic catastrophic health conditions, but one of them is that life is uncertain. You didn't ask for this, it happened. Body, mind, spirit, what's going on emotionally, physically, they all work together, body, mind, and spirit. And emotions affect, obviously, sexual function as well. It's all, as does illness, treatment, so it's all tied together. So what I do is I encourage my clients to develop resilience, to communicate, to talk things out, to get support. And I just want to say, you all know this already, men are not talking about their feelings. They're not talking about their emotions. They're not talking to their doctors when things come up emotionally. They're not bringing this up anywhere. They're not talking to their families. They're trying to be strong. So we talk a lot about emotional wellness, healthy intimacy, and really just, I call my practice Prepared for the Road Ahead, and the road is an ongoing road in helping, again, clients be ready to deal with the emotional aspects and getting support in that. So thank you.
Gary, one quick question. If you have a patient, what advice can you give to a newly diagnosed patient in terms of recognizing the symptoms of depression? Because one of the issues I faced was I didn't know what was going on with me. I knew something was wrong. I didn't know what it was. But what do you watch for?
It's a really good question. What I often do is talk to my clients. I'm an educator, I'm a therapist, but I think at heart I'm really a teacher. And I talk to them about symptoms of depression. More and more we're also talking about anxiety. We live in the age of anxiety these days. And a chronic condition, health condition is another reason. But I talk to them, I educate them on the symptoms. I give them a handout. I teach them to self-monitor and to self-soothe. And to look at when them monitor themselves, and then teach them, here's what you do with you if these are emotions they're experiencing. Because as you mentioned so well, suicide, PTSD, these can all come down the road if someone's not really coping emotionally. It's so important.
Thank you.
Thank you.
Maha?
So I specialize in reconstructive urology, and I see my patients generally after they've been through the process of treatment. And I'm a big patient advocate, and I can't tell you how many times I have the patient that's sitting in my clinic telling me that no one told me that this is going to happen. No one shared that this is a possibility. And I always feel bad. And I encourage patients to kind of have these conversations open. So if you're someone who's still going through the process or evaluating their options, I cannot emphasize the importance of actually talking to your doctor about the potential complications that can happen from your treatment of choice for your prostate cancer. As I always say, really picking a treatment for your prostate cancer is not really about just picking the treatment that works for the cancer. It's picking the side effect profile that you are willing to work with. They're all good treatment options, but they all have unique side effects. And whether it's surgery, radiation, watchful waiting, active surveillance, any of those treatment options, it always comes with a side effect profile that is unique to it. Treatments for prostate cancer really have a major impact on patients' quality of life. I've had patients who told me, I've been feeling great and I had absolutely no worry in the world. I was looking forward to my retirement to just spend it golfing and traveling and doing all sorts of fun stuff. And someone did a blood test on me and told me my PSA is elevated. One thing led to another. I'm now sitting in a plastic wrapped recliner because I can't hold my urine. I leak all the time. I don't go out in public. I'm depressed. I'm suicidal. My quality of life took a nosedive. And while complications happen, there are solutions for them. There are treatments for sexual dysfunction, orgasmic dysfunction, climacturia, urinary incontinence, things that can have a lot of impact on your quality of life. And generally, a lot of the patients do not have access or the conversations that happen with their treating providers about what's available out there for them to be treated with. It is sort of a double-edged sword. The vast majority of treatments for prostate cancer are not done in academic institutions. These are smaller centers that quote success rates that come from academic institutions, but they might not be necessarily the success rates for that particular treating provider. And the patient is sort of given biases from that physician that, the risk of urinary incontinence is 15%. Well, that might not be in your hands. That might be the series from a bigger institution that have done thousands of these procedures. So having the patient actually question what their provider is telling them is important. And I do think just awareness, spreading the awareness about the options for incontinence. There's things from the same-day procedure with devices that newly came into the market and FDA approved, like PROACT, to things that are time-tested, like the artificial sphincter that's been around for almost 30 years, to things in between and invasiveness for sexual dysfunction between pills and injectables and penile prosthesis. There are a lot of modalities that are available at our disposal to help improve patients' quality of life that unfortunately a lot of the patients do not have access to and do not get to discuss it with their providers, partially because the reported outcomes between what the patient is perceiving and what the provider is seeing, there's a big discrepancy there, and sometimes the patient really have to be the driver of those investigations.
You want me to talk to you?
You bet.
All right. So as a clinical sex therapist, I tend to see these sexual dysfunction as a sexual functioning concern. We live in a culture that thinks about our sexuality as solely related to our genitals. We have an entire palate. Our entire body can be very sexual. Right? We're not taught this. We're not encouraged to talk about this. Right, but we have a lot of opportunities. So when it comes to prostate cancer specifically, I want to say first, it may be really obvious. I don't have a prostate. I don't have a penis. Right? So being able to come and talk with a female, right, around that is often very difficult because that's not something that our culture has encouraged. Right? So a lot of the work that I do is to help rewrite our narrative. So I see this as an opportunity to create how you want to be sexual, how you want to be sexual more consciously, rather than what is default sexuality. Oftentimes, this requires a partner. It doesn't matter if you're in a heterosexual relationship or if you're in a same-sex relationship, or if you're a male that has sex with men, right? if you have a partner, they become part of the solution. They become part of the narrative. And we have to integrate that into the care that we provide around prostate cancer. This is often left out. So what I hear from people who come in is like, well, I've been diagnosed with cancer. Cancer tends to have an image right away of death, right? Would I rather die or be sexual? So often it's our sexuality that dies, right? And this is one of the ways that we feel really, really alive. It's one of the ways that we really thrive and connect with one another. So it's a really vital part of us feeling very alive. So what we can do is rewrite how that looks. And in that, there is loss. Right? There is loss sometimes of really obvious things, sensation, ejaculation. Right? That's a loss for a partner as well. It's not just a loss for the person who's been diagnosed. And so coming up with really creative ways. So there's a lot of vulnerability that goes along with this. So you need somebody very safe. You need somebody that you can talk with about issues you probably have never talked with. I'm an advocate for sexual hygiene, right? If I said to you, hey, don't brush your teeth anymore, right? I don't think anybody would say, you know, I think I'm going to take that advice. But when it comes to really connecting with how you are a sexual being with your genitals and with your entire body, and creating sexual hygiene so that you have a place where you can really thrive sexually, that you have a place where you can experience sexual play, right? So arousal comes in many forms, but we don't live in a culture that really promotes it. So this is a really important piece that I see in rewriting the narrative following diagnosis.
Could you tell me if you have any recommendations for couples, for example, where the man has been recently diagnosed, in terms of communication about the potential effects of treatment? Do you have some advice for that? Because it seems to me if you can't communicate before, it's only going to be much, much worse when you're afterwards and dealing with the effects of treatment.
One of the recommendations I really like is creating a mutual sexual journal. Right? So initially, when we're sitting across from somebody and we're talking about our sexuality, there's so much vulnerability, and unconsciously we're taking in all these cues, right? So if we didn't grow up in a family of origin that promoted healthy sexuality, we didn't really get it in school that promotes a lot of fear, right? Fear-based sexuality, right? Then we don't really know how to talk about our own pleasure. And when we're doing that face-to-face, there's a lot of anxiety. Now we have this loop that can be created, right? It's better off that I don't talk about it. So what I often have couples do is start a mutual journal, right? Where they talk about, like, I'm afraid to talk about this, right? I'm afraid my penis will never, ever be effective again, right? Where a partner is able to say, I'm afraid I'll never be able to take you in again. Mm-hmm. So that eliminates that piece of anxiety, and we work towards titration, right? Rather than that immediate vulnerability that often leads us to shut down. So we have to find ways where we titrate toward, rather than just do it, right? That just do it usually leads to a cycle that has more detriment than it does benefit. So that's something that I like to recommend.
Can you tell me exactly what you mean by titration in this context?
Yeah, very good. Okay, so a titration may be if we start with a mutual journal that has less of a threat when we're sitting across from somebody, right? When we're engaged sexually, especially in a long-term relationship, that sexual engagement usually gets really patterned, right? So we tend to do it the same way. It looks the same way every Sunday night with the lights off at 7 p.m., right? And there's not a lot of play that's involved with it, right? So first I may have a couple, and again, that's whether it's a heterosexual couple or a same-sex couple, is actually begin to talk about how they have patterned their sexual encounters together, right? So normally there's not any communication about that. Right? So they start there, right? And then I titrate them to move even forward. What are they interested in now? What do they feel like they've lost, right? What are the things that they're open to? So they continue to titrate, right? More and more vulnerability, right, with less threat, until we can move into talking about it directly, right? Because I'm going to ask people to engage in exercises they've never, ever engaged in, Right? So if I do that in my first visit, I'm unlikely to see those people again. Right? So it's an important thing to titrate through. And then we move into like mutually journaling about what kind of sensations outside of the genitals, right, are pleasurable. That's a really key experience because, like I said, our whole body is an erotic palette, not just our genitals. So we titrate that way. And then we move into how do they form sexual fantasies in this journal. One person starts it off, the next person carries it through, right? And the whole time they're also seeing me. So they're in an environment that hopefully I've created is very safe and really confidential and can introduce totally different ways of being sexual together. So that titration looks like that. We move it through slowly so that we have an experience of it and an experience of connection. Does that make more sense, Jim?
Absolutely.
Okay.
Thank you. I don't know how much time we have left.
20 minutes.
Okay. But I think at this point we could take questions from the audience.
Yes, my question has to do with the psychological effects from prostate treatment. To make a long story short, we have a group of guys, approximately 12, that we get together and we play golf. And approximately 5 weeks ago, one of the members called me up one evening and says, I'm going in tomorrow morning to have prostate surgery. So I said, what? He said, we're going. He repeated it. So he went in, and we didn't hear anything from him for about 5 days. I texted him, I called him, no response. When he finally called me back, his story was they went in to do the prostate surgery, and they had so many complications, mainly severe bleeding, that the surgery could not be completed. So as of now, I have this large scar, and the prostate is still there. So my question to you is, what could I do, because he sounds like he's a wreck right now, last time I talked to him. What can I do to assist him to get through this? Because we're kind of worried about it because of how, since then, he has gone, we can't get in contact with him. We've piggybacked to go around to his house, and we haven't been able to get in contact with him as of now. And if I do, I am going to get in contact with him. What can I do to sort of like guide him without him thinking I'm getting in his business?
Yeah.
That's good.
I'm not sure the question is, what is the question exactly? I'm sorry.
I think the question is, he has a man in his support group that's showing symptoms of depression and emotional illness, and what can we do? I mean, I think speaking as a support group leader, the first thing is you're doing exactly the right thing by talking with this gentleman and giving him an open forum where it's secure to express his thoughts and concerns. I think if you can take that and refer him to a mental health professional that you're comfortable with, and if you can't find one, we'll help you. Gary will help you. And I think that's the answer. So I think for the moment, you're doing the right thing, but the next step is to try to help this gentleman get some professional help, because it made all the difference in the world for me.
It's a very good question. Just want to make sure I answered it clearly. What I always, when in a situation like this, I say don't diagnose or say you're depressed, but be evidence-based. Say, I've noticed that you seem isolated because you don't talk much. I notice that you seem sad. I call, you don't answer. I text, you don't respond. I'm concerned about you. How can I help? And those are magic words. How can I help? And then I'd like to help connect you with some help. For you, would you like me to do that? And the person may say no. You may need more teachable moments where you see it again. You can say, I just noticed this. I really want to encourage you to get some help. It's treatable. If you're feeling bad, if you're feeling low, this is treatable. And then offer to help connect them. I would just say very quickly, organizations like us too has resources. Your local American Cancer Society probably has resources of therapists who can help in situations like this. I would also say if you're on managed care, Medicare, you can go to a website and get names of therapists, go on Psychology Today, cross-check them to see what their qualifications are. You can Google on therapists who work with individuals with chronic conditions. You can do some research and get to the right person also. And as Shelley suggested, you want to talk to somebody who has some background in chronic conditions and knows how to help.
Question here.
Great question.
There's a gentleman here who has a question.
I have one here. To the gentleman with the tie on, I don't remember your name, I'm sorry. But,
Fine.
It's not me.
The story you told with the person who felt fine, was looking forward to his retirement and that, and all of a sudden there's this PSA test that says there's something wrong. I tested at, what was it, 39 or something like that? I have absolutely no symptoms whatsoever. And I'm thinking, what might happen if I decide not to do anything except eat very well and exercise and get plenty of sleep and do fun things?
Well, on the short term, and I don't treat prostate cancer, so I'm probably not the best person to answer your question, but on the short term, you probably will continue on doing well. A little longer term, the disease tends to grow beyond the reach of the available modalities. And when we talk about cancer treatment, we talk about control, we talk about cure, we talk about organ-confined disease. We talk about disease that is still in the prostate, that probably your only chance for cure is when it is still in the prostate and you treat it before it actually spreads out. So while I do share the story of the patient who was feeling perfectly fine, was diagnosed with cancer, suffered from the complications, I'm by no means dissuading patients from actually trying to pursue treatment because you get a window of opportunity to address the condition. We're here to really highlight that if you happen to be one of the patients that are suffering from complication of the treatment that are impacting your quality of life, there are options for you. There are things that maybe you haven't had the chance to discuss before you made the decision. Maybe you've discussed them, but they weren't really on your mind. You were really just focusing on cancer control. You weren't really thinking about, okay, maybe I will be dry and be able to socially continue on with my life without having incontinence episodes, but maybe you didn't really think about leakage when people are sexually stimulated, which is a condition that people rarely talk about before treatments. So we're here really to kind of highlight these situations to tell people that there are options to treat them. You don't have to go on for the rest of your life. It's okay, your doctor who treated you for prostate cancer isn't going to take it personal if you're going to tell him, you know what, you did a great job controlling my cancer, but I am having this problem with erectile dysfunction. Could you help me with that? A lot of patients feel grateful and they feel they don't want to bring it up to their urologist. A lot of urologists do not want to admit it that their treatment caused this, or radiation oncologists do not want to kind of face the fact that maybe this treatment is associated with a lot of these side effects that have to do with urinary dysfunction, sexual dysfunction, all of the other stuff. And what we need more is an open conversation about this stuff in advance. And when it happens, we acknowledge it, we move on, we provide options, we treat the solutions. We have a lot of treatments that are scientific, that are evidence-based, that would help improve your quality of life tremendously. This is a very vulnerable population, and a lot of modalities take advantage of this. You know, you probably have all heard of some modalities that patients with sexual dysfunction are being offered such as shockwave, low-intensity shockwave therapy. And none of that stuff is really scientifically supported with outcomes or with evidence that it could improve on the treatments. Yet it's being offered, and these are really, capitalizing on the patient's vulnerability and lack of knowledge. And that's why we need people to talk about this so that they can weed out what really doesn't work from being offered to patients and use them when they're really at a vulnerable spot in their life.
Question here.
I think I would add to that looking back to the immediately prior presentation, they talked about shared or informed decision making. So you really need to consult with your physician or maybe a different physician, somebody that you trust, and really have that dialogue, because there are consequences with any decision you make. If you decide to do nothing, that will have consequences down the road. It's almost guaranteed. And the same is true of all of the treatment options. But you need to understand up front what the benefits and risks are. And you need to be in the hands of someone that you're talking with about that and feel like you're being heard.
Question here.
Yes,
Good morning,
hi.
gentlemen.
Good afternoon. My name is Cynthia
Who is-
Lindsay again.
who is?
I have a question that might be, hopefully the panel can answer it. If not, I think it may be a question for Dr. Zachery. My husband, I wish we had heard a number like 39. We didn't hear number 39. We heard 5,000.
Oof.
My husband's number was PSA was 5,000 when we discovered it. So we went to a urologist who was also an oncologist, and he tried the hormonal therapy to get the numbers down. He said it was very aggressive. So we got the numbers, like you said, we got the numbers down. It went from 5,000 to 2,500. The next time it went down to like 1,300 and then 750. But for some reason, after 5 months, it shot back up to over 5,000 again. And we had to do something much more aggressive as Dr. Heath is treating my husband. So in the process of trying to get that number down, of course, you had to lower the testosterone, and it results in erectile dysfunction.
Right.
So based upon what I think Dr. Zachery said, if in fact the cancer feeds off of testosterone, what would happen if he said, can I have a blue pill or something, take something? Is that going to increase the testosterone and be counterproductive? Or should he be looking at something else to help with the sexual dysfunction?
Correct. I'll take a quick, I know we're running out of time. I'll take a quick stab at this. So when you're treating an advanced stage of cancer by suppressing the testosterone, it is, you can't suppress testosterone from one end and replace testosterone from the other end. You would be fueling the growth of the cancer. But when you talk about the problems with testosterone, which are mostly sexual dysfunction related to lack of interest in sex, dropping in sexual desire, testosterone doesn't really affect the actual mechanics of erectile function per se. It mostly changes the desire that starts the whole process. So there are modalities that we can use in terms of treatment, whether it's in the form of oral pills or injectables, that we can help restore sexual function until the patient is at a point where they either can get off their hormone replacement, hormone suppression therapy, or if they are, for example, after surgery, the prostate is out, the disease is controlled. Some patients could go back on hormone replacement and have testosterone replacement. The data is a little controversial about this, but there's some more support to say for people who've had complete cure of their disease, they can potentially have testosterone replacement therapy to restore that sexual desire, but that's a very small sliver of the population.
Question here.
I want to jump in here before we start to another question, because one of the myths is that sexual desire is only driven by hormones. And sexual desire is not just driven by hormones. It requires effort. So we have this myth in our culture that that's how it's natural, right? And we're not encouraged or taught to put effort into the expression of desire, right? We need to be more playful, right? We need to experiment more. All of those have vulnerabilities. We know how to want. Whether we have hormones or not, we know how to want. And it's like, how do we channel that so that it feeds our sexuality? So there are other ways too. And secondly, that, you know, by the time people actually find somebody like me, it's been years. So now the pill hasn't worked. Nobody wants to inject their penis anymore. The pump got, you know, their testicle got caught in the pump. They're never going to use that again, right? So these things have been really entrenched over years, right? So it's really opening it up to look at it very differently. Yeah. So these sexual functioning concerns are not just hormone-based, right? They're connected to how we were shaped around our sexuality. They're connected to how culture speaks to sexuality. So I just want to offer you a bit of hope, right? That can look differently.
They're calling time on us. We'll take one more question.
Here, I wanted to, first of all.
Yes, what I did, I had a question. It's going to be a very short question.
We have a... We'll take two.
It'll be a very short question. Now, I want to know about causation. You hear about certain work environments that cause cancer, certain things that cause cancer. What causes, do you know, what triggers this? I'm trying to figure out what triggers cancer. I'm breast cancer, you know, testicle cancer, any kind of cancer. Is there something, one thing, I don't know if you guys are the right guys to ask, but is there one thing that we found out that can trigger prostate cancer, breast cancer? One thing.
Again, I'm not an oncologist. I don't do treatments for cancer. And I think Dr. Reichert is kind of a better person to answer this. But I can tell you that there isn't a single factor that triggers prostate cancer. My understanding, it's a combination of genetics, environmental factor, possibly things that are related to diet, but there isn't really a single factor, and I think you can probably answer this in a better way.
For adult cancers, many different things coming together. Oh, God, no, I'm live. There's not one thing. So we talked about inherited risk. That is one thing. We know that there's environmental exposures that we haven't understood yet that are probably another thing. Our diet and exercise and obesity is probably another thing. The chemicals we are exposed to at work in our life probably are a small thing. We don't know because there's so many different parts being brought in. It's really hard to narrow it down to one specific thing. The only things that we do know for sure of is that smoking increases lung cancer. That's clear. Sun increases skin cancer. That's clear. And then really hazardous exposures at work, and I mean constant, continuous, many days, not one day of it, also increases that risk. So all of these things are small parts of a big puzzle that we are trying to figure out.
Thank you.
Thank you. Thank you.
Stress is huge.
Yeah, let's have the last question. The panel's available afterwards to talk to you all. You've been very patient. Thank you.
Because I'm not the boss.
First of all, I want to say today's fabulous. I've learned so much. It's hard to keep up with it all. You know, I'd kind of like to get a couple of business cards or something yet. But I have been doing this for 30 years. I was a stage 4. I had my surgery at the Cleveland Clinic with Edson Pontus. I lost my prostate, half my bladder, part of my right kidney, and all the lymphatic system from my legs with 13 active lymph nodes. So they said, go home, do a will. You know, you've got 8 weeks to live. Somebody said that. So I love my doctors. I had fabulous doctors. Radiologist I went to, bright young guy, said, man, I'm looking at your chart. He said, you've had nothing but the finest doctors in the Midwest. And I found out fine doctors then refer you to other fine doctors. So I've had top-notch care. I don't have many complaints along that line at all, but it is exhausting to run this marathon for 30 years. And I'm full of piss and vinegar, and I try all sorts of things. I finally tried Prevenge. I noticed no difference at all. Maybe it'll help me live longer. But I've been very aggressive in my treatment. But I just have fatigue. And what I don't see my very fine doctors doing saying is, here are all these resources outside my office. They are too busy. But since they're going to be the same for all of us, if you're lonely, here are support groups. If you need support for other prostate patients, here are the groups. If you need nutritional assistance, here's where you go. And I've been hearing these things today. And I gave up on dating. I was married for 20 years. She walked out on me with my 3 children as soon as I was diagnosed, and I raised the girls half-time. But they're all over the country. They're not here for me. So since women really seem to be, in couples, the glue for society, you know, I end up going up to people and saying, hey, do you know I had cancer for 30 years? You know, I just blow people away. So that's what I'd really like to see you guys and anyone else hand out to our caregivers. Because when if you sit down in the middle of this saying, great, you know, this drug that's killing you just dropped your PSA from 17 to 0.008. Well, of course they're happy. I'm still not arriving yet. So, thank you very much.
Thank you.
I will be in the far right corner. I'm happy to talk with any of you about any of this. I'm pretty desensitized to it, so know that you can ask me anything. Feel free to meet me there. And, right?
Thank you. Yeah. Thank you all.
Thank you all.